All right, so impaled objects in the cheek. The biggest thing with this is that you want to watch out for bleeding inside the oral cavity, because that could lead to the patient aspirating, and also we can't swallow raw blood, right, without vomiting. So
I can't see the PowerPoint.
Oh no, okay, let me reshare again. Resume share. You see it now?
Yeah.
Okay, cool. All right, so the biggest thing with impaled object inside the cheek is that you want to watch out for bleeding within the oral cavity, because that could lead to aspiration and also vomiting and nausea, like it says here. And that's because your body, we're not made to digest raw blood. So that's why external wound care will not stop flow of blood into the mouth. So you want to examine the site, both inside and outside. Obviously, look for any bleeding, and if there is bleeding, stop the bleeding. If you find the perforation and can see both ends, remove the object. So if it is easy to do it and it won't cause that much damage to the patient, by all means take it out, because if the patient's talking or any little thing happens to that object, it could cause bleeding to occur, even if it's not already bleeding. So your best bet would be to take it off if it's small and it won't cause too many issues. Take it out, and then you can put some gauze on the inside between the cheeks and the gum, and then on the outside, and even have the patient apply pressure on the outside of that the injury. So that's one form of an impaled object in the cheek. So like it says here, allow for the patient the blood to drain. So you would want to put him in a recovery position on their side if there is no spinal damage done. That'll help out the patient, at least for drainage, and so they won't asphyxiate with their own blood or become nauseous from swallowing that blood. So obviously the airway is going to be a very big deal for this patient, and we want to be a little extra attentive with the airway because the trauma was in the oral cavity, dress outside the wound, and obviously give them oxygen. Oxygen. Like any other impaled object, if we decide to leave it in there because we think that taking it out might be too much of a big deal, then stabilize it in place however you can. So for an impaled object in the eye, same concept. Try to stabilize it with either bulky dressing, or you can also use a cup, a little small paper cup, the ones that are used for to get water from the dispensers, the water dispensers. If you poke a hole on the very bottom of that cup, it can be used in place of bulky dressing. And this is an example right here, so you can use this. If the impaled object is longer, obviously you would want to make a hole on this side, so that you don't compress it down any further, obviously, and it's secured in place. And again, there is no set protocol for securing objects in place. It's just however you can make it happen, make it happen. So what's an avulsion again? What did I say that was?
That's when something is kind of torn off.
Yes, it's a tear. So something is torn off. Exactly. Good job. Avulsion. So this is how to treat an avulsion. So clean the wound, the surface. Obviously, it doesn't have to be super clean, but take off as much as possible without spending too much time on it. And then you want to put whatever was torn off, if it's still attached to the body, put it back in place, and then control the bleeding and dress it as needed. Okay. And like I said, the reason we don't really have to focus too much on leaving it super clean is because when you get to the hospital, they'll take care of that for the patient there. For an amputation, this part is going to be completely cut off the body. You can try direct pressure, depending on the location and what is actually amputated. But if it's severe bleeding so bad that you just know that direct pressure is not going to help out, it's okay to go to the tourniquet and not waste time with direct pressure. Who here remembers where I apply a tourniquet in comparison to the actual injury site itself?
It's
Where
2
would I
inches
put it?
above.
Perfect. 2 inches above the wound. What if there's a joint 2 inches above the wound? Then what? Like if the injury is 2 inches below my elbow, we don't want to
above the elbow.
above the elbow, right? Because if we put a tourniquet on a joint, it's gonna be dislodged. It's gonna come off from too much movement. Good job. So as far as care for an amputated part, so you want a rapid and sterile dressing. And if you can, put it in a Ziploc baggie. That's probably also a good idea. And keep it cool. But the biggest thing is you don't want to put the amputated part, the body part. You don't want to put it in direct contact with ice. You want to wrap it around something and then put it in there. Do not immerse amputated part directly in water or saline, either. So for burns, there's three classifications of burn. You have your first degree, second degree, and third degree, and we'll go into it in a bit right now. See, may involve more than just the skin, obviously, because we have organs, we have muscles underneath the layers. So depending on how severe the burn was and how long it lasted will dictate how much damage there is and where it is and how far down the damage is. So if respiratory structures are affected, swelling may occur. Now, if swelling occurs, that's going to prevent our patient from breathing adequately if swelling occurs in the airway, somewhere along the airway. And of course, this can become a life threat. So that, again, it goes back to not letting any nasty burns or nasty trauma take your attention from your patient's ABCs. You really always want to be attentive and not lose track of what really matters here. So do not let burn distract from spinal damage or fractures. Classifying the burns, the agent, the source, the depth, and the severity, they all matter as far as classification. So such as chemical and or electrical burns, report the agent and when practical, the source of the agent. So if you know what actually caused the burn, if it wasn't a fire, it's a good idea to either write that down, document it, and if you can't even take a picture of it, just to show the doctors, give them a better idea of what they're working with. See, never assume the agent or source of the burn. Always be sure of it, okay? Always gather information from your observation of the scene. Okay, we got that down. So these are your three different classifications. You have your superficial, partial thickness, and full thickness. Superficial means that the epidermis was affected. It's the very top layer. Partial thickness means that the dermis, the epidermis, and the dermis, both layers were affected. Full thickness, we're talking about all the way down to the fatty tissue and maybe even the muscle, and in some severe cases, all the way down to the bone. Now, there is a fourth classification of burns, and it's not in this textbook, but you will find it in other textbooks, and that's a 4th degree burn. So a 4th degree burn, which is also full thickness, but there's so superficial, let me back up just a little bit. So remember how I said that there's like 2 different ways of saying everything in the medical field, that everything has 2 names? Well, superficial is also a 1st degree burn. Partial thickness is a 2nd degree burn. Full thickness is a 3rd degree burn. But in some textbooks and even just in some places, some hospitals, full thickness has 2 subcategories, 3rd degree and 4th degree. 3rd degree means that it went down to the muscle. 4th degree means that it went all the way down to the bone. That's what that means. So here you go. Please take a minute or 2 and write these down. You will come across this again. Again, superficial burn, 1st degree. Partial thickness burn, 2nd degree. And then we'll continue on. So I'll give you guys a minute or 2, and then we'll move on.